Hello, my name is Sandra Breizada and today I'm going to show you how to assess the abdominal cavity. Before we assess a patient, especially the abdomen, we need to make sure that the patient will go to the bathroom and void so we can avoid the bladder containing some urine fluid. We will provide to our patient privacy, and we will ask the patient to lay down on the bed on supine position. For that purpose, I'm going to use this toy, and we will leave uncovered just the abdominal cavity. So as we know, we need to remember that the abdominal cavity is divided in four quadrants: the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Also, the abdominal area is divided into 9 regions. The regions are above the umbilical region. We have the epigastric, umbilical, and hypogastric, the right and left hypochondriac region, the right and left lumbar region, and the right and left inguinal region. It's very important when we are about to assess a patient, we provide adequate lighting that will provide us a really good visual examination when we are performing our inspection part of the assessment. As I said, we will start with inspection. The inspection will comprises of observation of the abdominal area. We're gonna check the skin for color, for any type of rash, any type of scars that the patient may have. Also, we're gonna check for the insertion and location of the umbilicus, how it is regarding the orientation of the midline, its insertion. Also, we're gonna check the abdominal contour for size, shape, and symmetry. And we're gonna inspect as well for any sign of aortic pulsation, any visual veins that we can see. And we're gonna, if for example the patient is complaining of having any type of hernia, we will ask the patient to bear down to see if there is any sign of protrusion of the hernias. And finally, we will check also for any distension, abdominal distension related to ascites or accumulation of fluids. After when we are done with the inspection, we'll proceed with auscultation. And the reason why we auscultate before palpate and percuss is because we don't want to alter any of the bowel sounds pattern. It's very, very important to assess the abdominal sounds or bowel sounds. For auscultation, we're going to use our stethoscope, and we're going to start using our diaphragm. We're going to place our diaphragm at the level of the ileocecal valve, and we're going to go from there into each quadrant, and we're going to assess for the bowel sounds. We're going to go clockwise. Okay, the right upper quadrant, the left upper quadrant, and the left lower quadrant. When we are assessing the abdominal sound or bowel sound, we have to keep in mind the average is between 5 and 30 clicks per minute. That's the normal that we can perceive, of sounds. But the average adult number is 15 clicks per minute. Once we are done with the abdominal sound, we will move into the blood vessels, and we're going to use the bell of the stethoscope. We're gonna place the stethoscope, the bell, right above the epigastric area. So we're gonna perceive the aortic, and then we're gonna move into the right and left renal artery, and then the right and left iliac, and then into the right, which is a little lower, and left femoral artery. It's very important. We didn't hear any signs of roots. Our book also talks about the portal system and the splenic area circulatory system that we have to auscultate. We auscultate the hepatic as well as the splenic to see if we can hear any type of bruit, which will be an indication of stenosis or obstruction. No, it's normal. Once we're done with the auscultation part, we will proceed with the percussion part. For the percussion part, we're gonna do this in all 4 quadrants, and then we're gonna move into this, the liver and the spleen, and we're gonna see the differences between, like, around stomach, tympani and dullness from stomach and liver, and we're gonna try to see the differences when percussing, and we're gonna take mark a little lines. So we're gonna try to establish the size of the liver and the spleen as we move from one point to another point. So we're gonna start with the right lower quadrant, right upper quadrant, left lower quadrant, right here, left lower quadrant. Okay, 4 quadrants, and then we're gonna move into the liver area. We're gonna use 2 landmark, which are, one is the mid-sternal line and the mid-clavicular line. So we're gonna start moving from one up and down, and once we hear the differences and the dullness, and establish some marks. Sternal, here. Okay, we're gonna measure here. It's supposed to be between 4 to 8, and this side of the liver between 6 to 12. That means that the liver of this person is within the normal range. And we move the same for the spleen at the level of the mid-clavicular line up to 1.1 to 1.2. Very good, normal. Okay, so once we're done with the percussion, we're gonna move into our last technique, which is the palpation. We're gonna use 2 different type of palpation. We're gonna use the light palpation, which is between the 1 or 2 centimeters deep, or the deep palpation, which is between 4 to 6 centimeters deep. We use deep palpation for to examine some masses, and we can do that with one hand or with both hands. So we're gonna start with light palpation around the abdominal area on each quadrant. And as we're moving from one quadrant to other quadrant, we're gonna ask our patient if the patient is experiencing any sign of pain or tenderness. Or simple, we will look at the patient's face and we will see if there's any sign of non-verbal cues of pain, like grimacing, Once we're done with that, we will proceed to examine the liver, palpate the liver. We're gonna try to put the patient in this position. So I will place my non-dominant hand or the costal vertebral angle, the level 11 or 12 vertebra, and the mid-clavicular line. I will ask my patient to take a deep breath, and I will try to palpate the border of the liver. Okay, and I will do the same thing here for the spleen. And there's some variation when the patient lays on the right side. So I can place my non-dominant hand, the CVA, costal vertebral angle, and I will try to palpate the spleen. Okay, the book said and mentioned about that we are able to palpate right and left kidney in the case of organ enlargement. For these purposes, because our patient kidneys are normal, we're not able to palpate the kidneys. Therefore, the only assessment that I can do is to assess for kidney tenderness. So I'm gonna place my non-dominant hand on the lumbar, at the lumbar right side of my patient, and I'm gonna make a fist. And the patient doesn't feel anything, no pain, no tenderness, and the same at the left side. Good, no pain. Okay, so finally, we will try to assess for ascites, and for that reason, I will use the technique, and I will ask my patient to place his or her hand at the midline, and I will place one of my hand on one side and tap the other one, palpating. So I will see any visual manifestation of waves of the fluid moving from one side to the other one. In this case, it's not visual, so I will say that it's negative. Once I'm done with my palpation, I will proceed with the documentation of all our findings. In this case, I will documentate the amount of quantity of the bowel sounds, if the patient experience or not any pain or tenderness. I will try to describe the size of the liver and spleen, and also some patterns in the digestion and elimination patterns of my patient. Thank you.